Today's guests are Janet Whiteside and Mark Muller. We join their conversation in the faculty lounge.
Getting a successful infection of all the tumor cells, because in a tumor mass you could have a huge number. You could have, I don't know, 10 to the 10th cells, huge number of tumor cells, even a small tumor. And trying to infect all of those cells with a virus would be problematic, I think. So that's another area of research that is sort of high payoff, high risk. Something we might look into down the road, 5-10 years, career project.
Well, I have two more questions. One is about clinical trials. I mean, are you a strong advocate that we should have more people in clinical trials? Because from my standpoint, it wasn't an option many times, or I would ask about it, and no, you're not a candidate for anything. But then I got the book of clinical trials. It's like about like this. So where should someone be that finds out, okay, I have cancer,
right? Okay,
they say they're going to operate, but what are my options?
Right.
And should I seriously consider clinical trials?
Yes.
Or tell me something about that.
First of all, if you're in a situation where you or a member of your family has cancer, you have to be your own advocate.
Yes.
Absolutely. You have to be informed. You have to be willing to, when we had the press release on our results with telomerase back in April, or April and May and June, I got many emails and phone calls from people who's either had cancer themselves, or their mother or their father, family member, asking me what to do. I always tell them the same thing. Be informed, be your own advocate. Because you can go to the National Cancer Institute, the NCI website, and you can research all the clinical trials that are out there. And you have to just beat the bushes, ask the hard questions, ask the easy questions, go out there and find out what's the landscape like. There may be a clinical trial for you. The clinicians, they don't know everything. These guys, they're good ones, they're bad ones, and there's everything in between, just like the rest of us. But they can't possibly be up on all of the clinical trials. It's an information overload for these guys. They've got to know, in their specialty, if it's a blood guy, if it's a hematologist, he knows what's happening in leukemia, lymphoma, myeloma, that kind of stuff. Right? But he may not be up on what's going on with solid tumors. You might have a primary in one organ and a metastatic disease to another place. You've crossed the line. Now there are other therapies. So, you've got to be the one to research this. And it's all out there. And you just have to go and dig for it. Now, having said that, clinical trials have set criteria. And sometimes patients that have been bombarded with therapy already simply don't fit. And you're not going to be able to, because the clinical trial regimen, the system it's not perfect, but it's what we've got, and it does work. But the whole system is based upon trying to normalize and make the human model as tractable as possible. So they try to set sometimes stringent criteria so that you get patients in a cohort that fit and that we can analyze. If there's too much that's been done, then the response and prediction and those things are difficult. So that's the problem. I mean, you may not qualify for the trial.
Now, can you go through like clinical phase 1, phase 2, and phase 3?
Yeah. So the phase 1 is designed to establish maximum tolerated dose.
Okay. And then phase 2?
Phase 2 is you've already gotten established that, and phase 2 trials are usually larger trials that involve multiple sites. So phase 1 can as well, but they're more extensive, and you've got a drug that looks like it has some success, and it's probably going to get approved, but you've got to really do the numbers at that point. So, and then phase 3 is just a further definition of that. Okay. I have not been involved in phase 3 trials. I've been involved in phase 1 and phase 2 trials at Ohio State. So, and I think, you know, just put a plug in for the University of Central Florida. You know, this is a place where people come to retire, and cancer is a disease associated with age, and we have a large number of cancer patients in this area. So, especially in Central Florida area, we need a medical school.
Yes,
it would be wonderful to see that we could get a medical school established with a comprehensive cancer center, and build it here. It's amazing what kind of value that brings to the community.
Right. Yeah.
And you know, it's something that I think will happen probably in my lifetime, I hope. But it would certainly help my work.
Right.
Because I've got my collaborations with people at Ohio State that I'm still involved with. But then I have a connection with that. I'm still a member of the Cancer Center, and I still have you know, ties with the Comprehensive Cancer Center up there. So that helps me. I have that inroad. But some of my colleagues don't. Some people that are doing very relevant medical oncology, basic science, don't have that opportunity. It's just an additional barrier. And there's nothing like having a physical location. You know, you've got to have a cancer hospital nearby, and we don't have a critical mass right now to make it happen, which is something that hopefully the Board of Trustees and will vote for this, and we'll get the governor on board, and we'll have the state government roll a medical school our way and make this thing happen.
Right. I would really concur with that, because I know in my line of research as well, it would be great if
and you're doing clinical stuff, as you said, yeah.
Right.
I'm going to ask you something. What's the funding like for people in your field? I mean, do you go to the National Institute of Health or one of these agencies?
We most certainly can go to the NIH, but because I'm more on the social end of it, it's much harder to get the funding that we would like to have for what we're doing. But we are not only going to the government funding agencies, but to private agencies as well, such as the National Alzheimer's Association, American Stroke Association, those types of things, looking for funding as well.
Because I mean, the funding bubble is definitely shrinking, and we have a situation in this country which is I hate to say it, it's a anti-intellectual environment that's developing. In my as a basic scientist and an academic, I see some very lean times ahead. And let's face it, we're baby boomers.
Yes.
We need to have basic science to prolong our lives. We need translational research.
Right.
And the NIH budget is going to get pared back. You know, in the Clinton administration, they were on a doubling program. I think it was in every 5 years or every 6 years, they were going to double the budget for the NIH. That's off the table. And now they're saying in '06, the funding levels are going to be, you know, 1 in 10 grants, 10% funding success. And, you know, the peer review system just doesn't work, because I don't believe any scientist, any peer group can say, you know, a grant is, when it's 1 out of 10 that's going to get funded, you can't tell which is the best grant out of 10.
Right.
You know, you can, then it becomes, is it an area thing, or we want to fund this particular area of research. Right. The system starts to get very muddy, and you know, we're pulling resources out of our biomedical enterprise in this country and diverting it into other things, such as the war and so forth.
Yes.
And now with Katrina and Rita bearing down on us, the pie is going to get sliced. It's a fixed sum game, right? The pie is going to get sliced even finer. There's been, I think, a misuse of our resources.
Yeah.
But that's, you know, and what goes around comes around. I mean, it's all going to come back. You know, this country, we're leaders in biomedical in the world. We're the leaders. We're the guys up front. And if we lose that fragile lead, it's going to be very hard to get it back. It's not easy, you know, playing catch up. And I was telling you about my collaboration. I have a group that I collaborate with in Seoul. And these are the guys doing the stem cell work. So, because they're not prohibited. You know, we have a limit on here in this country. And what's going to happen is they're going to pass us by. And this is a really negative impact value on our leadership position in the world in biomedical research. That's my own little bias on politics, but
no, I think it was interesting. I was recently at a conference, and it was using virtual reality, mixed realities in rehabilitation, and it was amazing to see what the technologies are over in Asia, what the technologies are over in Europe and the Middle East, compared to what we're doing. And I think some of it has to do with the availability of funding, the priorities that we're setting, that they were further along than what we are.
Well, the other thing too is like I noticed in Japan, for example, they have a system of entrepreneurial funding, like we have venture capital here. They have similar models over there when you have intellectual property and you want to start a company or an enterprise. But their view on these projects is more long term. Like here in this country, if you don't hit pay dirt in 3 years on a project, then you lose your funding. I mean, the VCs, the venture capital, just kind of starts to dry up if there's not some income streaming that happens pretty quickly. And in my field, it takes a while. You know, this stuff is not, number one, it's not cheap. You got to take a long view. It takes a while, and it might be, it might be 10 years before you see a payoff. And the Japanese and the Koreans, and I'm sure this is true in China. I know it's true in Taiwan. You know, they take a longer view. They'll go 5 years, 7 years, or longer on projects that they deem worthwhile. It's patience. They've got this patience about it, and that we seem to lack. But I've been involved. I do some consulting in Asia, and I go to of course I go to Seoul, and I have business contacts in Tokyo, and I see how these guys operate, and it's just the model is different.
Is their funding cycle longer than?
Their funding cycle typically is 5 years. But at their government institutes, like the RIKEN Institute, I think it's longer than that. I think, and also the money is very green. I mean, they get more of it. I'm pretty discouraged about biomedical funding in this country right now, actually. We all go through this. You write grants and they get rejected, and if you don't have a thick skin for failure, this is not for the weak of heart. You gotta, and if you've gone after NIH money, what it's like. I mean, it is. You pour your heart and soul. It takes me about a month full time to write a big proposal and to get everybody on board, collaborators and letters and support and the university behind it, and then to write the thing, and then to have it get rejected. I mean, it just, it's getting so difficult these days to get your science funded, and I wouldn't want to be a young person coming up. I wouldn't want to be an assistant professor starting out in this funding climate, because tenure decisions sometimes are made based upon your ability to get grants.
Absolutely, yeah.
You know, I don't know how it is in your field, but in what I do, it's nerve-wracking. I mean, it's good training for purgatory. That's what I tell the assistant professors.
Yeah.
But I want to know more about this virtual reality thing you're talking. And the reason I'm interested is it's totally unrelated to the science that I do, but more related to I'm active in aviation and I'm a pilot, kind of, you know, using simulators,
Right.
which is a big deal now. The FAA has endorsed this so-called 142 program, where they're starting to put more of the trainees before they ever get into an airplane into sims, and let them see how that works.
Right. Well, the idea of it came truly in collaborating with people in the College of Optics and Photonics at UCF, and then the Institute of Simulation and Training, and then Computer Sciences. And some of the folks over at IST, even though they said that they have great collaborations with people in computer science and with the military, they really wanted to see if they could apply what they're doing to the area of rehabilitation and medicine and that type of thing. So I kind of got brought in when they were out searching for how could they expand their technologies. So we've been talking for a couple of years. We put in a large grant and it did not get funded. So we were kind of at the point of, do we keep going after some funding, or do we start to run some pilot projects and show proof of concept? So that's where we are right now with what we're doing. And we specifically looked at transfer of learning. So typically someone that has had a stroke or has had a traumatic brain injury will go to rehab. Nowadays it's much shorter than what it used to be, but 2 weeks to maybe a month, and then they're sent home. Well, frequently what they have been able to acquire and learn does not transfer well once they get to the home. Like we as therapists can say, well, yeah, I think that they can you know, problem solve how to make breakfast or something. And they get home, they can't do it. And yet though we say, yeah, you know, verbally they can do it, and here in the clinic they've done it, but they can't do it at home. So the question becomes one of how can we better equip them for that transfer. So the idea was to scan someone's home environment, bring that then into a simulated environment, and see if they could learn in the simulated environment and take it back home. And so what we were able to do was we took a patient's kitchen, went out there, scanned it, brought it back, and then fed into different engines that added the audio and the visual and the special effects. And when we watched this particular patient, though, we noticed that he needed to anchor himself somewhat. He could not remember where the cups, the plates were, where the cereal, where anything was. So he just did this wandering behavior. Now, he had been back in the home for about 8 months. He still could not remember where anything was in the kitchen. So we just noticed him, and so our idea was we would build a kitchen with some of the critical elements in it, but not everything. Then he would wear a head-mounted device that when he had on the head-mounted device, he actually saw his kitchen.
Oh, that's interesting.
And then we would have him go through and make breakfast. So that's what we did. We created the critical elements, and then he wore a head-mounted device, and we had him make cereal, bagel and cream cheese, and make coffee. So we would have him script it before he would go in, and then he would go into the kitchen and do it. And what we were watching was his ability to internalize that script and do it, and then was he, through just procedural memory, able to start through repetition, remember where things were. Well, what was so interesting is that this particular participant never recognized this kitchen as his kitchen.
Really?
So after we had gone through all the trouble, you know, to have the head-mounted device, so that he actually saw his kitchen. He could look out the window, saw what he would have seen out the window in his home, look out the bay window in the kitchen area, to the cars. Everything was like really well done, but he never recognized it. But what we were able to prove was that when we took him back home after he was only trained for 5 times in the simulation, was he did have much shorter time accomplishing the task, and his tracking behavior was much more continuous, and it was to the target. So whereas he took about 5 minutes initially with making cereal, in the simulation he peaked first like at 6 and then went down to about 4. When he went home, he did it in 2 minutes. So even though he consciously did not realize what he was doing, we actually proved that yes, there was transfer of training.
So it's just a hands-on thing. But how do you ascertain that? I mean, how did you ascertain that he wasn't able to make that connection from the virtual world to what his home was? I mean, was it just by asking him and saying, hey, you know,
does
what do you
this
see?
look like your kitchen? You know, no. Have you ever seen this before? No. So that was interesting. The other thing that was interesting for us was that he actually, even though he would walk into the environment and then put on the head-mounted device, when he had the head-mounted device on and was trying to do his kitchen activity, he would actually reach for virtual cabinets. He would reach for the virtual stove. So in his mind, what he saw then was real to him at that time, even though he consciously did not recognize it as his house.
What were the physical cues besides the virtual? You said you had to have some.
Right. We found that he needed the counter space, so he needed something that where he could go, he could kind of balance himself there. This is where I'm supposed to be, that type of thing. So we had the counter space, some of the cabinets, and a refrigerator and a pantry.
Fascinating. But the technology that goes into this is, you said you went and scanned his. I mean, I'm just curious about the technology. That is it a 360-degree camera then that shoots the room?
Right, and then it captures that data, the points. Then that was put into computer program in which then they were able to simulate the kitchen. Then we also took digital photographs and overlaid those as well. Yeah.
Are there other things that you've explored that where you could go with this in your field specifically?
Right. I think eventually what we would like to see is technology that they could actually take home with them. Okay. So and that would be kind of limitless. The ideas, but something so that they could be cued in their home environment as to what needs to be done. So I think a couple of other populations that I'm particularly interested in would be patients that have Alzheimer's disease or some type of memory impairment. Because just as cancer seems to be on the rise, people that have Alzheimer's disease or some dementias are most certainly increasing, and with the baby boomer population aging. So I think trying to find technologies that we can allow people to be more independent in the home is where we eventually want to be with this. So not only bringing the technology into our clinic, but then equipping them with technology somehow so that they could go home and use that. So that's kind of where we hope to be eventually with it.
And how, I mean, is that a real practical application? I mean, do you think that in the next few years that this is something that could evolve? I mean, it just seems to me that there's a lot of technology associated with it that on a case-by-case basis. I mean, as a research topic, it's fascinating, but is it? And I'm sure you thought of this, but is it really practical?
Well, probably not right now, but we most certainly hope it will be in a few years.
What I'm thinking too is that you know, the cost of computers and digital cameras, all this stuff is getting cheaper and cheaper.
Yes.
So in that regard, you know, my biggest concern would be just the rate limiting cost. You know, how cost effective is it HMO environment where they're wanting to pay less and less and get more and more.
Right. Yeah.
But yeah, that would certainly be fascinating. What have you had any involvement with using this stuff for aviation by any chance? 'Cause that's really, I'm really fascinated by it. Probably not.
I know though at the Institute for Simulation Training at UCF, they are involved with driving. I think with some long distance, like truck driving type of thing that they've been working on, but that's another project. But I don't know if they've done anything with aviation yet. Okay.
And if I can just ask about your background a little bit, because you said you're from the state of Illinois. Where did you do your training and where did you get your degrees?
Started at a private school, Augustana College, and then went to Vanderbilt, and then went to Indiana University, and then got down here to Florida.
How long have you been here?
Actually, I came down here about 30 years ago, but then left, and we went out to Kansas and taught, and then came back here about 10, 11 years ago.